we're going to be discussing ultrasound-guided needling technique, and it's going to be a stepwise approach. We've kind of got our little setup here where I'll be demonstrating some key points about how to, hold the probe, how to set everything up and line things up such that you will have the hopefully optimal chance of good visualization of your needle while you are doing injections. So in looking at palpation-guided versus ultrasound-guided technique, many of us started off with the palpation-guided version of injections here, and a lot of times it is faster than an ultrasound-guided technique, at least in the beginning. Now, with regards to ultrasound-guided technique, it does allow for more confident injection of high-risk structures, especially. It also requires a lot of significant training, but hey, what useful skill doesn't? So, do you need 0.2 millimeter accuracy for something that has that big a margin of error? However, if you go down to the perineural level here, then your margin of error is much smaller if you're doing a hydrodissection. So this requires the use of thinner needles, being able to minimize your distance, being able to hit your target with the least number of redirection attempts, and that does take some skill. That requires like thousands of iterations to be able to do a safe, effective, minimally painful injection quickly. It takes thousands of iterations. Then the last step in terms of your, I guess you could say, mastery, if you can ever call it that, mastery of your injection technique, is to be able to do all of these 4 steps without needing to think about it. And that allows you to multitask. All right, the rest of the lecture today, we're going to be talking about these 5 broad categories of how to optimize your technique. As you can see here, letter A is setting up for the injection, so that's before you even do anything. Letter B is just prior to inserting a needle. Letter D is how to optimize your needle visualization, and what I like to refer to as avoiding a random fishing around for your needle. And then there's a list of some needle technique drills, which we have listed at the end. If you have a long needle on the end of a 10cc syringe and you're holding it in the usual, what I call forehand grip, it's hard to control. A smaller syringe is easier to control because the distance from the needle tip to your control surface, which are your fingers, is shorter, therefore you have better control. Your handhold has to be such that you can do any of those 10 directions in small increments with ease. Any other probe hold, in my experience, there are at least 1 or more of those 10 directions that you cannot do easily, right? But again, you'll find that it's going to make everything easier in terms of moving your probe to find your needle, to find your structure with those micro movements. So in my practice, and what I recommend is that you've got your ultrasound machine here, and then you have a second screen that's offset approximately 90 degrees. This way you have control. This allows you to operate with just yourself, and you don't need an assistant to manipulate the ultrasound machine. But actually, let me raise the table up because, as I was saying before, the table is too low. The screen, it doesn't look that the screen is very high, but it's actually a little bit too high for me. So this screen, my line of sight, if I use the pointer as an indicator, my line of sight is about like this. So the screen is maybe almost a foot too high for my visual line of sight in this current configuration. Like the screen height currently is about the right height for me standing at my height as a human being, right? So can we go to the hybrid picture-in-picture of ultrasound small screen and video large screen, please? What you want to do is to move the probe, if you look at the video, move the probe sort of away from yourself, away from where you're going to be inserting the needle, such that the distance traversed by the needle is not too far from your target. Now, if you had the opposite, let's say your target's over here, now you got to traverse all the way across to hit your target. And so you have to think to yourself, okay, is my needle angle going to be more like 45 degrees, which is approximately here? You have to have some sense of what that at least reasonable starting angle is of your needle to hit your target. It is less important with in-plane technique because with in-plane you can kind of, if you have good technique, you can see that needle traversing across the screen and you can correct your needle angle more easily. But point being, you evaluate your tissue, your target depth, and then you calculate the angle of the needle. And again, it's all part of that whole geometry piece, which again I'm not going to go into too much right now, but most people will insert the needle approximately a centimeter away from the probe. Anyhow, What you don't want to do is you don't want to stick the needle right up against the tip of the like you can't really move the probe around because the needle's already in the way. There's potentially some sterility issues unless you've got sterile everything. And in some cases, what's interesting is there are some people that have damaged their probes with the needle because they're actually poking their probe with the needle and they don't know it. Let's say that you've determined that the correct angle to reach your target is about 45 degrees for the, all right, and as I'm looking at it, that looks to be about 45 degrees when the probe is at 0 degrees vertical. Well, what happens if you're scanning a structure like the patellar tendon where in order to minimize anisotropy, you got to tilt that thing, let's say 20 degrees. So now the needle, instead of being 45 degrees to vertical, it's now 45 minus 20, about 25 degrees to vertical. Well, now if you heel toe away from you, you have to shallow out the angle of your needle to match. And same thing if you heel toe towards you, then you gotta increase the steepness of your needle. So you really have to take into account the probe position before you insert your needle, because this probe doesn't care about gravity. It's at whatever position it's in, wherever it is in space, and you got to make the needle match the probe. Where you have a close insertion, but you have to have a steeper angle, versus number 3, where you have a very distal insertion, but you can have a flat needle angle. And there are pros and cons to each one of these. This is the kind of diagram version of what I just demonstrated. Where in this left side example, the probe is at 0 degrees so that the needle is 45 degrees to vertical. So now if the needle is going to be 45 degrees relative to the probe, guess what? I mean, to have a vertical needle angle like that just looks bizarre, but that's exactly what's necessary if the probe is tilted 45 degrees, which is a pretty heavy tilt, instead of just my ugly mug here. But instead of having the needle lined up appropriately with the probe, the needle will track off in the direction of your dominant hand, and the probe will track off in the opposite direction. So me being right-handed, the needle 90% of the time tracks off to the right. This is one of the most important points in this entire presentation, because this is the thing that's going to keep you safe when you're doing needle technique. Okay, so there's my needle in plane, and I'm going to heel toe a little bit towards my needle so that you can see it a little bit easier. You can see, because this is a 21 gauge needle, you can see the bevel. So I'm going to rotate the needle, and you can see how that bevel is like rotating there, about in the middle of it. But heel toeing this way, heel toeing towards your needle like this, is going to allow the ultrasound beam to be more perpendicular to the needle and allow for better, brighter visualization of that needle. So now if we do the same thing and we're looking at the ultrasound image, right, so there's the needle when I'm not heel toeing, it is at neutral, which is like that, right? Everybody forgets to do this. Why? Okay, so I think it's actually in one of my other presentations, but I talk about those 5 directions that we're talking about, or the 5 movements, heel toe being one of them. Well, how are you supposed to consistently get a little needle, which is like 1 millimeter wide, to always be exactly in the beam path of a beam that's only half a millimeter wide? So now, let's say you're going 5 millimeters to the right and 5 millimeters to the left. You just increased your field of view from 0.5 millimeters to 10 millimeters, right? So, E number 1, determine the necessary angle or depth correction that you need to get the needle to be in the right place. I see that my target is, about like 20 degrees offset from my current needle angle. So, in other words, my needle angle is too far to the right. Why? Because usually the needle tracks to the side of your dominant hand. So I realized that, okay, I need to then retract the needle so I don't bend it, then correct my angle moving towards the left, and then reinserting again. And if I just basically try to move my syringe and change the needle direction without retracting the needle, I'm just going to bend the needle. So what you have to do is you have to retract the needle till it's almost out of the skin, then you change your angle, whatever you need to do, and then you reinsert. So estimating the needle length allows you to know how much needle is left below that skin surface. Now if you've got a 4-inch needle, then obviously you're going to be retracting a whole lot of needle before you change that needle direction. So E3 is basically the natural evolution of E2, where you got to retract that needle sufficiently, that we just talked about. But the problem is that when they need to change that needle angle, instead of keeping the needle angle the same, because when you retract that needle angle, you got to keep the angle the same so you know how much you have to change it. Like if I'm here and I notice, oh, my needle is too deep, I have to make my needle angle more shallow. And now after retracting the needle angle is now, let's say, 15 degrees more shallow than it was.